Cisatracurium, formerly recognized as 51W89 and marketed as Nimbex, is a bisbenzyltetrahydroisoquinolinium that has effect as a neuromuscular-blocking drug or skeletal muscle relaxant in the category of non-depolarizing neuromuscular-blocking drugs, used adjunctively in anesthesia to facilitate endotracheal intubation and to provide skeletal muscle relaxation during surgery and mechanical ventilation. It shows intermediate duration of action. Cisatracurium is one of the 10 isomers of the parent molecule, atracurium. Moreover, Cisatracurium represents approximately 15% of the atracurium mixture. History. The generic name Cisatracurium was conceived by scientists at Burroughs Wellcome Co., now part of GlaxoSmithKline, by combining the name atracurium with CIS, hence Cisatracurium, because the molecule is one of the 3 CIS-CIS isomers comprising the 10 isomers of the parent atracurium. Atracurium itself was invented at Strathclyde University and licensed to Burroughs Wellcome Co., Research Triangle Park, NC, for further development and subsequent marketing as atracurium. As the secondary pharmacology of atracurium was being developed, it became clear that the primary clinical disadvantage of atracurium was likely to be its propensity to elicit histamine release. To address this issue, a program was initiated to investigate the individual isomer constituents of atracurium to identify and isolate the isomer S associated with the undesirable histamine effects, as well as identify the isomer that might possibly retain the desirable properties without the histamine release. Thus, in 1989, D. A. Hill and G. L. Turner, Ph.D., both chemists at Burroughs Wellcome Co., Dartford, UK, first synthesized Cisatracurium as an individual isomer molecule. The pharmacological research of Cisatracurium and the other individual isomers was then developed further primarily by R. Brandmeier and William B. Waysteeler, Ph.D., both of whom were pharmacologists within the Division of Pharmacology at Burroughs Wellcome Co., in collaboration with John J. Saveries MD, who at the time was an anesthesiologist in the Department of Anesthesia, Harvard Medical School at the Massachusetts General Hospital, Boston, MA. Thereafter, the entire clinical development of Cisatracurium was completed in a record short period from 1992 to 1994. The team of scientists was led by J. Neil Weekly Ph.D., Martha M. Abudonia Ph.D., and Steve Quissy Ph.D., in the Division of Clinical Neurosciences at Burroughs Wellcome Co., Research Triangle Park, NC. By the time of its approval for human use in 1995 by the U.S. Food and Drug Administration, Burroughs Wellcome Co. had merged with Glaxo Inc., and Cisatracurium was approved to be marketed as Nimbex by Glaxo Wellcome Inc. The trade name of Nimbex was derived from inserting an I to the original proposal, Nimbex, which stood for Excellent Neuromuscular Blocker. Preclinical pharmacology. In vitro studies using human plasma indicated that Cisatracurium spontaneously degrades at physiological pH via Hofmann elimination to yield laudanacine and the quaternary monoacrylate. Subsequent ester hydrolysis of a monoacrylate generates the monoquaternary alcohol, although the rate-limiting step is Hofmann elimination. In rat plasma, Cisatracurium is also metabolized by nonspecific carboxylesterases, a rate-limiting step, to the monoquaternary alcohol and the monoquaternary acid. Clinical pharmacology. As is evident with the parent molecule, atracurium, Cisatracurium is also susceptible to degradation by Hofmann elimination and ester hydrolysis as components of the in vivo metabolic processes. See the atracurium page for information on Hofmann elimination in vivo versus the Hofmann degradation chemical reaction. Because Hofmann elimination is a temperature and plasma pH dependent process, Cisatracurium's rate of degradation in vivo is highly influenced by body pH and temperature, just as it is with the parent molecule, atracurium. Thus, an increase in body pH favors the elimination process, whereas a decrease in temperature slows down the process. One of the metabolites of Cisatracurium via Hofmann elimination is laudanacine. See the atracurium page for further discussion of the issue regarding this metabolite. 80% of Cisatracurium is metabolized eventually to laudanacine and 20% is metabolized hepatically or excreted renally. 10 to 15% of the dose is excreted unchanged in the urine. Since Hofmann elimination is an organ-independent chemodegradative mechanism, there is little or no risk to the use of Cisatracurium in patients with liver or renal disease, when compared with other neuromuscular-blocking agents. The two reverse ester linkages in the bridge between the two isoquinolinium groups make atracurium and Cisatracurium poor targets for plasmacholinesterase. Unlike mivacurium, which has two conventional ester linkages. Adverse effects: histamine release, hypotension, reflex tachycardia and cutaneous flush. Unlike the parent, atracurium, Cisatracurium affords a much better pharmacological profile with respect to eliciting histamine release, bronchospasm, pulmonary compliance. To date, Cisatracurium has not been reported to elicit bronchospasm at doses that are clinically prescribed. Laudanacine, epileptic foci. Cisatracurium undergoes Hofmann elimination as a primary route of chemodegradation. Consequently, one of the metabolites from this process is laudanacine, a tertiary amino alkaloid reported to be a modest CNS stimulant with epileptogenic activity and cardiovascular effects such as low blood pressure and a slowed heart rate. As a tertiary amine, laudanacine is unionized and readily crosses the blood-brain barrier. Presently, there is little evidence that laudanacine accumulation and related toxicity will likely ever be seen with the doses of Cisatracurium that are administered in clinical practice, especially given that the plasma concentrations of laudanacine generated are lower with Cisatracurium than those seen with atracurium. Research: a recent study showed that Cisatracurium pre-treatment effectively decreases the incidence and severity of pain induced by propofol general anesthesia. Synthesis: treatment of 15-pentanediol with 3-bromopropionyl chloride gives the corresponding ester. Dehydrohalogenation of the ester with triethylamine then gives the bisacrolate. 2. Reaction of that unsaturated ester with tetrahydropapaverine. 3. Leads to conjugate addition of the secondary amine and formation of the intermediate. 4. Alkylation with methylbenzene sulfonate forms the bis-quaternary salt, affording cisatracuronium. 5. Further reading: Caldwell-Ger, 1995. New skeletal muscle relaxants. Int. Anesthesia Clin. 33. 1. 39-60. DOI. 10.1097 0004311 1995 000000003. PMID 7635557. Hull C.J. 1995. Pharmacokinetics and pharmacodynamics of the benzylisoquinolinium muscle relaxants. Acta anesthesiol scanned. 106 supple. 13-17. PMID 8533537. Saveries J.J. Wastela W.B. 1995. The Future of the Benzylisoquinolinium Relaxants. Acta anesthesiol scanned. 106 supple. 91-93. DOI 10.1111 J 1399 to 6576.1995 TBO 4317 X PMID 8,533,554 Esmaeoglu A Akin A Muzrak A Turk Y Boyachi A 2006 edition of Cisatracurium to lidocaine for intravenous regional anesthesia. Quote, J. Clinan East, 18. 3. 194-7. DOI 10.1016 J. J. Clinan 2005.08.003. PMID 16,731,321. Melanie C. DeVivo P. Lorno C. Mastronardi P. Novelli G. Romano E. 2006. Cisatracurium vs. Vecuronium. A comparative, double-blind, randomized, multicenter study in adult patients under propofol, fentanyl, N2O anesthesia. Quote, Minerva Anesthesiol. 72. 5. 299-308. PMID 16,675,938. Sarah C. Oliveira A. 2006. Cisatracurium. Myographical and electrophysiological studies in the isolated rat muscle. Quote, Fundum Clin Pharmacol. 20. 3. 291-8. DOI 10.1111 J 1472-8206.2006.00395 X PMID 16,671,964. Katsung, Bertram G. 2011. Basic and Clinical Pharmacology. 12th ed. New York. McGraw-Hill. ISBN 9780071764018.